Welcome. We are talking about bile acid malabsorption today. Britton already did a great job of going through the disclaimer, not medical advice as for educational purposes. And let's take a look at my learning objectives for you today. I'm going to introduce to you the StoolOMX report. If you haven't seen it before, we're going to talk about bile acids, primary bile acids and secondary bile acids. We're going to talk about our short chain fatty acids, so saccharolytic and proteolytic. And I have a case study example that we're going to go through, and then we'll talk about when do we want to consider adding that StoolOMX to the GI map. So if a few of these things mean nothing to you yet, you're in the right place. That's where we're headed with this today. So let's get going and then we'll do some questions. So I do have a lot of reference slides in here for you, which I'm going to click through really quickly. Again, they're there for you to reference when you do a StoolOMX add-on for things to think about. The start of my reference slides here are how you can access our educational resources. There's a ton of learning in there. We've got our resource library and our DSL Academy that house a ton of content. And then we have the StoolOMX information. You can find this on the website. Down in the bottom here is going to show you the reference guide, the sample report, and the product brief that you can find. And then this is just reference to our DSL Academy and this StoolOMX overview video. So the slides that I'm going to breeze through, you can get detail on those in this video. So go ahead and reference that if needed. So what is the StoolOMX? This is an add-on only for the GI map. It's a 3-page report with a summary page on the front. We get to see 25 bile acids, both primary and secondary, in both percents and quantifications, and I'm going to go through that in detail, and 9 short-chain fatty acids. So we're getting saccharolytic fermentation and proteolytic fermentation metabolites. And you see those both in percents and quantifications. So I'm going to orient you to what that report looks like and what we're looking at. So that first page, this summary page on the StoolOMX report, is where we're going to get the bulk of the information that we need for interpretation and making alterations or treatment decisions. So what we see on this page, you can see it's split into 2. So we've got bile acids on the top and short chain fatty acids on the bottom. So I'm going to go through each one of those sections separately, but let's take a look at what we have. We have total bile acids, secondary bile acids, primary bile acids, and then you see these donut charts where you get to compare those percentages of your patient results to the reference range. So it's really nice to see visually. And then we have our LCA to DCA ratio. Again, we'll go through what all of these things mean shortly. And then the second half of the page is these short chain fatty acids. So you get your major straight chains. You get to see the percentages of each of those individual straight chains. And again, your donut chart. So you can compare your patient results to the reference range. And then we have a ratio in the corner here, which is our straight chains to our branch chains. And again, we're going to go over those and what they mean. In the middle page of the StoolOMX add-on, this is where we're getting big detail into the individual primary bile acids, which are on the top there, and the secondary bile acids that are on the bottom there. Again, I want to keep your attention mostly to that front page, especially when you're starting out. That's where you're going to get your most valuable information. And then the last page of this add-on, you're going to see the short chain fatty acids broken into 2 groups. The saccharolytic straight chains, which are saccharolytic metabolites, and our proteolytic branch chain, which are proteolytic metabolites. Again, I'm going to go through that. And the bottom of the page there, you're seeing a diagram of the physiology of bile acids that you can refer to. All right, so what is a bile acid? This is the basis of what we need to know to move forward and looking at this. And so let's start with our overview. So bile acids, and we're starting out by talking about primary bile acids here. So they're made by the liver. They are conjugated or tagged with a taurine or glycine, which is going to make them more water soluble. They're then stored and concentrated in the gallbladder. And they're released into the duodenum when we eat food. That's a signal from CCK. So they are going to aid in the emulsification or the breakdown and absorption of fat. You can think of them like having a detergent action in breaking apart that fat. And we expect that 95%, so the vast majority of those primary bile acids should be reabsorbed in the distal ileum. That's the end of the small intestine before you go into the large intestine. You're going to hear distal ileum a ton today. So that's our orientation of where this reabsorption is happening or should be happening. And 5% are going to move into the colon, and our normal flora are going to transform them from primary bile acids into secondary bile acids. So this is a healthy microbiome is going to do that transformation of converting from our primary bile acids into our secondary bile acids. Okay, so we know that primary bile acids help with fat digestion. What do our secondary bile acids do? So they have a lot of different roles in the body. So first, they are antimicrobial. They have antimicrobial properties to help modulate the microbiome. They help with immune regulation. So they regulate our Treg cells, and they have a big influence on the balance between inflammatory and anti-inflammatory immune cells in the gut. They have a big impact, can have a big impact on motility if they're out of balance. So high levels are typically associated with diarrhea, and low levels are typically correlated with constipation. They also have a multitude of metabolic impacts and impacts on our mucosal health. So these next slides, this is what I was talking about, these reference slides, and I'm going to breeze through them for you. They're here for your reference, and they're going to go through each section of the StoolOMX, and then they're going to have each of them this chart where things that we want to think about when those levels are high or when they're low. So these are by no means an exhaustive list, but they're a great place to start, and they can, again, the details of them can be found in that StoolOMX overview video that I highlighted. I'm going to click through nice and fast here so we can get to the fun stuff. So total bile acids, our primaries, our secondaries, our LCA to DCA ratio. And then this slide, what I want you to get from here, the transformation of primaries into secondaries by our normal flora. And how they do this is through these two enzymes and two steps. So step one is called deconjugation. And our normal flora are going to use an enzyme called bile salt hydrolase to do that. And then step two of that transformation from primary into secondary is called dehydroxylation. And the enzyme that our microbes are going to use there is 7-alpha dehydroxylase. So on the next two slides, you're going to see which microbes have these enzymes. Okay, so that step one of deconjugation using bile salt hydrolase, you can see on the left the microbes that we can see on the GI map, and then on the right, the ones that we don't see on the GI map. And what this shows us is the additional information that we get about the microbiome from the StoolOMX. So if we have impaired conversion, we're thinking about all of these microbes. And then these are the ones that have 7-alpha dehydroxylase. Okay, so that was the top portion. That was looking at bile acids. So that's the top half of that summary page. Now the bottom half is looking at our short chain fatty acids. And I'm going to explain what is a saccharolytic straight chain fatty acid and what is a proteolytic branch chain fatty acid. Okay, so simply put, short chain fatty acids are small fatty acids that are 0 to 6 carbons long. They're produced by our bacteria from fermentation of either those dietary carbohydrates. So our overall heading is short chain fatty acids. And as you've seen, we've got two groups under that heading. So our first group is our saccharolytic straight chain fatty acids. And these are a result of carbohydrate fermentation. It has the same acronym or short form, that SCFA, as short chain fatty acids. So just be aware of that. They are referring to different things, but they have the same abbreviation. The second group of short chain fatty acids, the saccharolytics, we expect to make up 90 to 95% of our total short chains. Okay, and our second group is those proteolytic branch chain fatty acids. And these are a result of our bacteria fermenting proteins. Okay, and so we expect that about 5 to 10% of that total of our short chain fatty acids is going to be made up of these proteolytic branch chains. Okay, so this is another look at that summary page of the short chain fatty acids. You get your total straight chains, and then we get the individual percentages of each of those major straight chains and our donut chart comparison look. Okay, and these are a couple more of those reference slides of what we're thinking about when either group is high or low. This is from the reference guide, and it's, again, a demonstration to show you which microbes produce each of these straight chain fatty acids. So again, look at the amount of information about the microbiome we get based on who produces what. So we have, again, this reference slide for our branch chains when they're high or low. And then this is my last reference slide before we get into the case study and what is bile acid malabsorption. So this is looking at what do we want to think about if that straight chain to branch chain ratio is high or low. So let's get into the case study and bile acid malabsorption. So our case today, and I'm going to review this again later on so that you remember what we're talking about. So this is a 39-year-old male with diarrhea. I suspected that it was potentially bile acid diarrhea. The onset of diarrhea, he's unsure of the exact timing, but he's had it for many years. A normal or a good day is 1 to 2 bowel movements a day, but lots of times he's upwards of 3 to 5 times a day, especially in the morning. Sometimes it's urgent. Form is all over the map, no undigested food, no blood, but he does have this incomplete feeling about a quarter of the time. And one of the big indicators for me to look at bile acid diarrhea is this streaking on the toilet bowl where it's sticky, it's not flushing down, it's sticking to the edge of that toilet paper or toilet bowl, hard to wipe, all of that. So to me, that's saying malabsorption or imbalance. Occasionally he reports mucus. Stress is really high, an 8 out of 10. This will come into play when we look at the test results. The nervous system is such a big impact on gut health and digestive output. So that's why I put that in there. And then on the Bristol stool chart there that you see on the right-hand side, he's 5 to 7, but mostly 5-6. So on the loose side, he has had type 4 bowel movements. And so he knows what a normal bowel movement's, but it only happens very occasionally. When we are thinking about diarrhea, I just put this in here again as a reminder that there's a big differential diagnosis list for diarrhea. So really making sure that we are thinking about and evaluating all of these pieces when somebody presents with diarrhea. Now we're going to look at the normal physiology of the bile acid feedback loop. So this is what should happen in a normal, healthy individual. So first, we have this, again, reabsorption of those primary bile acids. So again, that terminal ileum, end of the small intestine, is where this should happen. So when we're getting reabsorption of primary bile acids in this location, that is going to activate this receptor, FXR. That's also going to be in the ileum, and it plays a really crucial role in regulating this bile acid metabolism. And one of our primary bile acids, CDCA, is an especially potent stimulator of this receptor. So when this receptor gets activated by our primary bile acids, we then get the production of this molecule, FGF19. So that's fibroblast growth factor 19. And that is also secreted from those ileal cells. And it will then enterohepatic circulation. That is the circulation between our gut and our liver. So we get that production of FGF19 in the ileum. It's going to travel to the liver, and that's where it actually inhibits the synthesis of bile acids. So that is so important, this feedback loop. Inhibits one of the rate limiting enzymes in bile acid synthesis. So if everything's functioning properly, this is what we see. But obviously, it's not always functioning properly. So what does it look like when we have bile acid malabsorption? So bile acid malabsorption or bile acid diarrhea is predominantly due to an interruption in what we just looked at, that enterohepatic circulation. So that is over on the right-hand side, that FGF19 and that blue arrow, that's that circulation again from the gut to the liver. So when we get increased primary bile acids in the large intestine or the colon, that leads typically to faster transit. That faster transit is going to mean that our good gut flora that is responsible for transforming the primary bile acids into secondary bile acids, that we are going to have a lot less time for them to do that job because transit is fast. We can also get changes in the microbiome when we have too many primary bile acids in the colon. So we can have one or both of those issues going on. We also have another receptor that's activated here, and that's going to be, again, our location here this is going to be in the start of the colon. And this is called TGR5, and it's located on a few different types of cells. So enteric neurons, smooth muscle cells, and enteroendocrine cells. So typically the net effect of having that stimulate is going to be an increase in motility. But I do just want to point out, because our bodies are very complicated systems, that when those enteroendocrine cells are, the TGR5 is activated on them, they are stimulated to release GLP-1 and peptide YY, which actually is going to slow transit. So typically, the net result is going to be faster transit, but that's one side effect there that we can have. And LCA is our most potent stimulator of that receptor. Okay, so again, we get a result. Bile acid malabsorption is going to result in excess bile acids in the colon, especially one of our predominant primary bile acids, which is CDCA. Okay, and again, that's our location that we're looking at, is that ileum into the colon. And when we have too many primary bile acids in the colon, this leads to a bunch of different outcomes. So it alters the water and sodium transport. It increases motility, so via that TGR5 that we just talked about. Too many primary bile acids in the colon also damage the mucosa, which is going to result in increased permeability, barrier dysfunction, all of those issues. We can get increased mucus secretion, stimulation of that defecation reflex, and those high amplitude propagated contractions. So that's that urgency here. When we look at a classic clinical presentation, this is definitely a scale, depending on the patient, as you can see in the case example. The reason I chose this case example is because it was not a glaring, this is bile acid malabsorption, bile acid diarrhea. It was a more muted form of it. And so I want to bring that to our thought process that can happen, that we can have all sorts of levels of these symptoms that I'm going to present to you. So that's going to be bowel frequency, that urgency. Some will describe it as very explosive, stool incontinence for some, bloating, excessive gas, abdominal pain. All of this results in this last one, which is huge, this altered quality of life. So think about your population of your IBS-D people, where they have a hard time leaving the house. They need to know where the bathroom is. All of these things really impact how they can move through the world. And so we can have a big impact on that. So let's take a look at these classifications of bile acid malabsorption. Now, it's not, to me, very important that you have to know which category they're in, but it is important to know the categories so that we, again, can know, is this a true malabsorption, or, as we'll see, we can have overproduction of bile acids. So type 1 is actually called secondary BAM, and it's secondary to some sort of dysfunction of the ileum. Again, that's where we want that reabsorption of our primary bile acids. So this can be due to Crohn's disease that affects the ileum, ileal resection, post-radiation for people who've had pelvic radiation that can alter the ability of the ileum to absorb, and microscopic colitis. And one other thing I want to point out is that you might see some of these in areas where you go, oh, I think that should go in that box or that box. And you do see a little variation in the literature, and it's mostly because they're really just starting to parse out the details of bile acid malabsorption. So I'm sure we'll see this get even more detailed over the next few years. But what happens with type 1, this is our true malabsorption. Failure to reabsorb those bile acids in the distal ileum, so they're spilling into the colon. So this is our true malabsorption. Type 2, they call primary or idiopathic BAM of unknown cause. So this is where our functional diarrhea, our IBS-D people come in. And in the literature over and over, they're stating a number that about 30% of people with IBS-D have BAM as their root cause. That is a huge number. Again, we can make a really big impact there. And if we can see that on the StoolOMX, that's going to help us to make a treatment plan for that person. So this is not typically going to be our malabsorption issue. It's actually hepatic overproduction, an alteration of that negative feedback loop that we just talked about. And this can be potentially from impairment of that molecule that I talked about, that FGF19. That's the one that circles back to the liver and inhibits or stops bile acid synthesis when we have them in the colon. And so this can alter motility, the cycling of our bile acids, and really here, it's not malabsorption, but overproduction. Type 3 is going to be our other conditions. And this is where some of these you might go, oh, that could go into potentially type 1 and impact the ileum and all of that. But we may have a mix of etiologies here. So this is going to be, we're thinking about this in post-cholecystectomy, which is a big one. Celiac disease, which I would argue could go in potentially that if it's affecting the ileum, the absorption issue. Bacterial overgrowth, which we can see on the GI map. Pancreatic insufficiency, which we can see on the GI map. Again, pelvic radiation can go in either, and post-infectious diarrhea. You can also see this on the GI map. And this outcome is going to be very similar to type 2. It's going to be really focusing on that hepatic overproduction. As I pointed out, we may have a little malabsorption going on with celiac disease and maybe even bacterial overgrowth. There's some preliminary research to say that there's an association between biofilm production inhibiting reabsorption at that ileum. So again, may have a mix there. And then the newest type is type 4. And that's going to be in those that have high triglycerides or are on metformin. And this is going to increase bile acid synthesis. So this is, again, a nice list or chart that you can look at when you're considering BAM. Now, how do we now test for BAM before the StoolOMX or seeing bile acids in the stool? Let's go through that because this is going to show us that the StoolOMX is such an easy and great opportunity to see these bile acids versus, what's available. So the first one that we see, and you'll see this if you're looking at the literature, this is one that you're going to see a lot. It's called the CCAT. And what they do is the patient takes in a radio-labeled bile acid. They're going to take an image of that about 3 hours after they ingested it and 7 days after. And then they have this scale that is going to go over the level of malabsorption based on what they see in those results. The advantages is that it is reliable and it's highly sensitive and specific. So sounds like a great test. So what are the disadvantages? It's quite costly, and the biggest thing is availability. So it's pretty widely available in Europe, but it's not available at all in the US and really limited availability in Canada. So not something that I have ever seen as that somebody's been tested for. There is a little bit of radiation exposure as well. Getting to be more common, we have the C4 serum test. This is a blood test, and it's testing one of the rate-limiting enzymes in bile acid synthesis. So if that C4 is high, it's indicating that there's an increase in production of bile acids from the liver. It's a simple collection, it's a blood test, but the disadvantage here is that we do need additional testing to confirm that it is BAM. So this test on its own is not diagnostic. The next test, 48-hour fecal bile acid test, is the gold standard in the US. Now, what they do with this is they're going to ask the patient to ingest 100 grams of fat for 4 days. And then the last 2 days of that, they're going to ask them to collect every bowel movement. Then they're going to analyze it. And again, they've got this level of malabsorption based on what they see. Advantage to this, we get a quantitative assessment. You get to see the level of malabsorption. But the disadvantages potentially that you can see here is that if somebody actually has BAM, they may already be limiting their fat intake to help their symptoms and to feel better. And we're asking them to provoke their symptoms for 4 days, eating 100 grams of fat, which is going to likely increase their bowel movements, increase their motility. And then we're going to ask them to collect all of those stool samples. It's a bit of a hard sell, so it's challenging, and the interpretation in the lab can be a little bit complex as well. And the last one, bile acid sequestrant diagnostic therapy. This is the one that I see the most, where they're just going to do a trial of a bile acid sequestrant based on the clinical presentation. And if the diarrhea resolves, they're going to presume that it's BAM. It is non-invasive, but really here, it's not necessarily a clear diagnosis. There's different reasons that bile acid sequestrants could stop diarrhea that are not only BAM. Bile acid sequestrants also have a lot of potential side effects, so it can lead to poor compliance in people as well. As you can see, not a lot of really great options for BAM. This is where seeing those bile acids and short chain fatty acids on the StoolOMX can be a game changer for people. So since we are talking about that IBS-D category being so big here potentially, and you could say that the case example is probably an IBS-D, even though he didn't pursue getting a diagnosis. And what are the patterns that we see? The ones that I've bolded, probably all on the left-hand side, you're going to see in the case study results. So we tend to see increase in LPS producers, histamine producers, mast cell activating microbes, Bacteroides phylum, and then a decrease in Faecalibacterium and our Firmicutes phylum. So we will see those coming up. So just a recap before we look at the test results. This is our 39-year-old male with diarrhea. I suspected bile acid diarrhea. It's been going on a long time. We're getting a wide variation in bowel movements. Really, this streaking, sticky quality to the toilet bowl is what led me to think about bile acid diarrhea and that there's some malabsorption potentially going on there. Again, I want to draw your attention to that stress because that's going to come in when we look at the test results, and then our Bristol stool chart. So let's take a look at the test results. So page 1 of the GI map, no pathogens. We have a low level H. pylori here. This could be commensal. It's not the top of my mind of things that I'm focusing on for this patient, but it is there in the back of my mind. Now for the commensals, we got a little bit of a mix here. So I always start with this phyla section at the bottom because Bacteroides and Firmicutes together are about a 90% representation of the microbiome. So this is like our overview section. We get a really good look at that overview. And we can see a couple of the main trends that we saw in the IBS-D microbiome. We're seeing Bacteroides trending high, Firmicutes heading towards trending low. I also want to point out with this Bacteroides phyla, we're going to see this group produces a short chain fatty acid called propionate. We're going to see that slightly elevated later on in the StoolOMX, and it's likely coming from here. And why are things overgrowing? What's creating a favorable environment is usually weak digestion. So that's where I was pointing out that stress piece. Stress really decreases our stomach acid, and that's going to change the environment, making it more favorable for overgrowth lower down. So that's where that comes in. Next, we're seeing an Akkermansia. These are mucin layer organisms, which is really imperative to the homeostasis of the large intestine of the microbiome. And so when they're low, I'm going to want to think about supporting that mucin layer. And then our Faecalibacterium being low, again, another IBS-D characteristic. But the other thing we want to think about here, and we're going to be able to see again in the StoolOMX, is butyrate production. So I'm looking at Faecalibacterium, Roseberia, and that Firmicutes phyla. So we have a general trend of low. So I would expect to see it low, and we will see it low. But that's, again, the benefit to being able to see what's actually happening on the stool. On page 3 of our opportunists, we have our classic strep, which again, usually there because of weak digestion. We've got a favorable environment. But I do want to point out that these guys are also mast cell activators, which was another characteristic of IBS-D. We also have Citra, and I forgot to point out there up above the staph and strep, a little bit of Pseudomonas. So we're also going to have that histamine production and LPS production. And then we have our Candida, and Candida can have big impacts on our bile acids and short chain fatty acids and vice versa. And so I'm going to highlight these links as we move through. No parasites or worms, and then our intestinal health markers all look pretty good. We just have this high secretory IgA. So this is likely in response to the immune system in the gut trying to mount a response against that Candida, but can also be reflective of barrier dysfunction, potentially leading to food sensitivities, food reactions as well. Okay, let's look at the StoolOMX portion here. So this is the summary page, again, the top half. So we're going to start with the bile acids, which is the top half, and then we're going to move to the short chain fatty acids, which is the bottom half of that first summary page. So what are we looking at? Our total bile acids definitely trending towards being elevated, and production or synthesis of these bile acids in the liver not deficient. I'm thinking about overproduction, I'm thinking about conversion, and I'm thinking about reabsorption issues. So we see high primary bile acids. So this could be an impaired reabsorption potentially. And then when I'm thinking about conversion, I'm looking at what's happening with our secondaries. They're really low. So this is showing me there's a lack of conversion from our primary bile acids to our secondary bile acids. So this is going to be a reflection of low microbial diversity. So we saw the additional microbes that we get information about by looking at these things. And even though the commensals on page 2, they didn't look terrible, that's the benefit to seeing some of these, is that we can see that, okay, so another portion of the microbiome that is helping with this transformation needs some support. And Candida can really impact this and impact our normal flora by competing with our commensals for nutrient space, altering the pH, mucin production, making that less favorable. So we'll look again at that even closer coming up. I do want to also point out this unique looking donut chart. So that red portion, which is other, that other category includes our primary bile acids. And you're going to see shortly that all of the primary bile acids are elevated. Those primary bile acids are dominating over everything else. So that's why we see that red portion of the chart taking up most of it. And then we see the LCA to DCA ratio. It's a little on the low side, but we'll see when we look at that middle page, DCA looks fine. LCA is a little on the low side. Again, I'm looking at microbial conversion here. So what's the connection between Candida and bile acids? Primary bile acids really can promote that Candida colonization. So that excess of primaries in the colon can suppress the host's immune system and disrupt our good gut flora. And our secondary bile acids, which are low here, those can inhibit Candida growth, which is really important. Those are low here. So we've got a really favorable environment for Candida with our high primaries and our low secondaries. And our secondary bile acids, particularly our main ones, LCA and DCA, actually have been shown to have direct antifungal action against Candida, which is really cool. Now, when we look at that middle page of the primaries and secondaries, this is where I wanted to show you, you can see all red. They're all high. And if you look at the exponents, that E number, and you look at the high end of the reference range, you're going to see that each of those are 1 to 2 magnitudes higher than the reference range. So this is significant elevation. And as I mentioned on the last slide, these can really promote that Candida colonization by suppressing the host immune response and disrupting the environment for our beneficial gut bacteria, especially this TCA, taurocholic acid. And this is the bottom half of that page. This is our secondary bile acids. And you can see we've got a mix of high and low, but the general trend here is low. And again, we get that from the summary page, but I do want to highlight a few things. The few that are elevated, this can be reflective of those imbalances in the microbiome that push some of these conversions, and that's potentially why we're seeing some of them high. I'm going to highlight 3 of them here: UDCA, TUDCA, and GUDCA, UDCA, GUDCA, and TUDCA. Lots of you have probably heard of TUDCA. Interestingly, all 3 of these are hepatoprotective bile acids. So we might be seeing some shunting towards these repair support pathways. And this is possibly response again to mucosal stress, microbiome dysfunction. I do want to draw your attention to, we'll talk about this later, as to why I didn't include TUDCA in my treatment plan. This can be a good reflection or a good place to check when you're deciding if there might be therapeutic benefit to something like including TUDCA. Okay, so now we're at the bottom half of that summary page, the short chain fatty acids, and we can see the total of our straight chains looks good, acetate looks good, and here's our butyrate, really low. And I alluded to this in the commensals. We had that low Faecalibacterium, starting to trend low Roseberia, and starting to trend low Firmicutes phyla. So this is going to mean that there's low availability of food for the colonocytes, impaired barrier function, and propensity towards inflammation. The high propionate, which is this next one here, I was saying likely due to that starting to overgrow Bacteroides phylum, that they produce propionate, and then we have low valerate. Okay, and then the short chain to branch chain ratio, what we're going to see with this, we'll look at the numbers specifically, but it's because both groups are low, but branch chains are even lower. That's what's pushing this ratio. Okay, so what do short chain fatty acids do? Why are they important? They regulate the function of the intestinal epithelial cells, they decrease inflammation, and they maintain homeostasis of that mucosa. And propionate and butyrate, as I was talking about, provide that ATP or that energy for those epithelial cells. So important. And having that low butyrate is going to have big impacts on barrier function and inflammation. And so what's the connection with short chain fatty acids and that Candida? So short chain fatty acids can drop the pH, making it less favorable for Candida to overgrow. So again, in vitro in studies, we're seeing short chains inhibit Candida growth. And lots of studies are starting to highlight the antifungal potential of our short chains being in balance, which is huge. We've also seen in a few studies that both butyrate and acetate, they can help potentiate or help the action of our whole class of antifungal drugs. So I thought that was really cool that we get this synergistic effect of those happening. And then we know Candida is a direct contributor to a loss of that barrier integrity, and there's a link to a variety of inflammatory disorders. So let's take a look at that last page showing us our straight chains and our branch chains. And again, what we're seeing here, overall trend is low, but those branch chains are really low. So this can be reflective of our, again, our low microbial activity or diversity overall. Also, potentially this low stomach acid, we're not breaking down our proteins effectively here. So quick summary of our most relevant findings that we looked at throughout. So there was a low level H. pylori. We had some dysbiosis in the normal flora. Also in our opportunistic overgrowth, especially with that Candida. We had a high secretory IgA, which is probably the immune system trying to do its job, potentially some barrier dysfunction, potentially some food reactions. And then we had our high total bile acids, low secondaries, high primaries, and then our generally low short chain fatty acids. So let's look at what kind of a treatment plan I put together for this. Now, you'll see that I bolded a few of these, and the bolded ones are treatment decisions that were either reinforced by or actually made based on those StoolOMX results. Because yeah, I may have assumed, but seeing that, I could see what a disruption there was in both the bile acids and the short chains. So for treatment, starting with nystatin, the timing depends on how the patient's responding and what their symptoms are doing. I always include Saccharomyces boulardii in my Candida treatment. We've got tons of great literature showing that it helps to outcompete that Candida, so it's a great addition. And then supporting the normal flora diversity. Again, if I was just looking at the GI map in this scenario alone, I would have had support in there, but it may not have been this robust. The amount of butyrate that I'm giving was helped, or the decisions made by what I could see there with the amount of butyrate. Soluble fiber and resveratrol, polyphenols and soluble fiber are going to feed those normal flora. But again, amount and when I started at really changed based on what I saw there. And the 50B probiotic helps to support the environment, but we also have a little bit of research suggesting that it might actually help to decrease one of our primary bile acids as well, CDCA. And then I've got a gut healing powder in there that includes NAG and acetylglucosamine to help that mucin layer for that akkermansia and ester. And then based on the StoolOMX results, I wanted to support what I'm calling the liver bile acid axis. And this is going to be a combo product with artichoke that's going to help modulate the bile acid pool, and milk thistle to support that liver function. And then we also had some dietary support. So I wanted to support stomach acid. Again, stress is really high. Stomach acid was looking low. I use an HCl challenge for that. We really wanted to limit to no alcohol, depending on what was available there, but always really wanting to bring that down. And then increasing intake and diversity of fruits and veg. So that is going to be my long-term goal for soluble fiber and polyphenols, but working on it in the short term to make those long-term goals. So that was what phase 1 looked like, but we do have some additional treatments that you can absolutely consider in these scenarios. Let's take a look at those. These are some natural bile acid binders and some pharmaceutical options. Now, a lot of these have research on them actually is from high cholesterol and binding bile acids as a route to reducing cholesterol. Clinically, we can make that jump because of their mechanism of action. A lot of providers are using these, and just like medications, it's not a one size fits all. Sometimes we need to try multiple approaches or different ones of these before we find the one that works for our patient. The first one that actually has lots of good research is psyllium. This is psyllium husk, which the husk is 70 to 80% soluble, and they bind bile acids to prevent their reabsorption. So they're actually really acting similar to our bile acid sequestrants, and we're taking those with food. Activated charcoal is a bile acid binder. lecithin, I always have trouble with that one, it will bind bile acids indirectly. And the support here in the literature, I would say, is limited. I do see clinically that providers are using this and getting success. So again, it's just another option I wanted to put out there. And then I was alluding to TUDCA and what the theory behind TUDCA, especially in these diarrhea cases, is that it might alter that bile acid pool again to make it more favorable and less irritating. And as I pointed out, you can use that to look at their level of TUDCA. So because his was high, I didn't choose to use TUDCA in this case. TUDCA is anti-inflammatory in nature, and it can have potentially some modulatory effects on that receptor, that FXR receptor, which we know helps to regulate that negative feedback loop. And then low-fat diet can absolutely be helpful in managing symptoms. Some patients will already have put themselves on this. Our prescription options are going to be our bile acid sequestrants. Again, can have lots of side effects for some people, can be helpful potentially when calming things down and getting that quality of life back. There are things called FXR agonists. They're not frequently used. They're really expensive and just not widely available. And then there is a potential for GLP agonists. This is specific actually to liraglutide, but I would say we need more research on this. There was a small, short 6-week study done on liraglutide and BAM, and it was really successful. But again, we don't know what that means for the rest of the class of GLP-1 agonists, and we don't know what that means long-term. So again, I keep your eye out for this. It's been something that's been brewing in the literature, but I wouldn't say we have enough to go off of that yet. So with all of that being said, who are we going to run this StoolOMX add-on on? So really top of mind is motility issues. That's going to include IBS-D. Remember, I mentioned up to 30% of those people have BAM as their root cause. Suspected BAM, obviously. Steatorrhea is fat in the stool, IBD, constipation, issues with the gut lining and mucosal health, immune imbalances and inflammation, which can include food sensitivities or intolerances and skin conditions like eczema. And then even in our metabolic disturbances and our aging and longevity. Just to wrap it up here, a few considerations that I want you to think about, especially if you're going to be consulting with us on the phone, which we are happy to do to go through these StoolOMX results with you. Really important to have that history, that background. What's their stool consistency and motility? If you're not using a Bristol stool chart in your practice at this point, I highly recommend it. I've included one there on the right. And having that information, as I've hopefully impressed upon you throughout this, allows us to further individualize our treatment plan and really target things even more when we have that. And again, insights into these motility issues, I want that to really be top of mind. Again, our inflammation, chronic gut lining dysfunction.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.